Are you on the line?
Yes, I am.
Hi, welcome. Thank you for joining us again this afternoon.
Thank you.
And I'm also wondering if Dr. Jeff Powell is on the line. And Mila, I think you're the one and only with us at this point.
Wow, that's pretty amazing.
So I'd be glad to approach this in a way that works for you.
Okay.
And it's interesting that yesterday we had two school nurses with us, and it really was an opportunity, as it was in a previous part one, to really orient it more towards school nurses than school-based health center providers. So I'd be glad to do that today, and also to give you a recap of last week. I don't think, were you with us, Mila, last week?
I was. I'm not sure if it was Monday or Tuesday, but I was for one of the days, and it was done early because the one woman had to go and get her child.
That's right.
Fast one.
That's right. Carrie Hopes from Roswell
Okay.
needed to go get her child. Thank you for that reminder. I thought you were with us last week, so
Yeah.
you got to hear that portion of the presentation. So you know about the requirements and the guidelines that we covered last week for prescribing psychotropic medications to be efficacious for treating depression and anxiety in students, and how that really emphasized pharmacotherapy and not merely the pharmacology, that is to say, therapeutic uses of the psychotropic medications. And in that presentation, I mentioned that we would really focus there on how to do things that are therapeutic with the medications as part of a larger treatment plan, a comprehensive multimodal treatment plan, and how there is a standard of care and quite a bit of empirical support for the combination of multimodal therapy, and in particular including psychotherapy along with psychopharmacotherapeutic agents, and not merely prescribing the medications alone. Well, today we're going to talk a bit more about the psychopharmacology in our objective to distinguish 6 major psychotropic medication classes and select those that are efficacious for treating student depression and anxiety. And Mila, I'm realizing that as a school nurse, you're not going to be prescribing these medicines, but I think it's useful for school nurses to understand how these medications can be used and what kinds of concerns can come up with students during your school days, and how you can contribute to the handling of those concerns and the communication about, and largely the communication about those concerns with students, parents, and a prescribing provider.
Yeah.
How does that sound to you?
That sounds good to me.
Is there anything else you would want me to consider in the kind of circumstances that arise in your work as a school nurse?
I honestly can't think of anything.
Okay.
But if anything comes up, I will let you know.
Please do. I'm counting on you.
Okay.
Mila, what school or schools do you serve in APS?
I'm at Chaparral Elementary School.
Okay.
It's on the west side. There's a lot of ISP kids, preschool, and it's, I think, about 900 kiddos.
That's really good size for an elementary school.
It's huge. But there's 2 nurses here, so we're really lucky.
That sounds really good.
Yeah.
By the way, has your colleague ever joined one of our webinars?
She has not.
That's okay. Please invite her, but if she chooses not to join us, I entirely understand.
She would be more into the asthma one. That's her expertise type thing.
That's just great. It sounds like you're familiar with our programs, and I think that's terrific. Since you mentioned ISP, I'm trying to remember, is that an intensive support program?
Yes, it is.
Okay. Good.
Yep.
Well, let's move on and talk about selecting psychotropic medications for student depression and anxiety. We know that clinical psychopharmacology offers various classes of psychotropic medications that have therapeutic benefit for student depression and anxiety. Older medications are being replaced by newer medications. Some are effective for anxiety in one respect, but are being replaced by newer, more beneficial properties in medications. Well, in looking at our objective for the 6 major classes of medications, of course I have to add another class, which are the others. But we basically have antidepressants, mood stabilizers, antipsychotic medications, anxiolytics, the anti-anxiety medications, alpha-2 agonists, psychostimulants, and that last other category. Now, I want to be clear, Mila, I'm not proposing that all of these medications be used for depression and anxiety. However, in one way or another, they basically all have at some point, but they wouldn't be what we would choose as first-line agents or perhaps even second choices for treating depression and anxiety in youth. I'd also want to add that the anxiolytic term is an older term, and it no longer implies that those are the medications of choice for treating anxiety, and we'll be getting to that shortly. Well, of the antidepressants in the first category, there are the SSRIs, we'll talk about those, followed by the SSNRIs, bupropion, others, and augmentation agents. Mila, you probably have heard of the SSRIs, or selective serotonin reuptake inhibitors. And I think for many, these medication names are very popular. Either they know somebody who's taken these medicines, many people have taken these medicines, they've been advertised in magazines and on television. Prozac, or fluoxetine, was the first one to come out in the later 80s, followed by sertraline. To this day, fluoxetine and escitalopram, or Prozac and Lexapro respectively, are the 2 SSRIs that are approved for youth by the Food and Drug Administration. And that's a fact that was covered last week when talking about FDA approved versus off-label prescribing. These medications act on central nervous system serotonin by blocking its reuptake. As I tell students and their parents or other caregivers, The antidepressant alone is not a pill containing serotonin. It's not a serotonin maker, but it makes the existing serotonin more available to do its thing. And I'd have to say that that is an aspect of psychopharmacology that I really appreciate. We're really modulating what the central nervous system does already and helping a known entity such as serotonin be more available to do its thing. Well, these antidepressants are not only effective for depression, but anxiety as well. And they've really become first-line agents for anxiety. They're excellent when there is anxiety along with depression. And whether it's considered part of the depression or a coexisting separate anxiety disorder, these are very effective medications. And they have some other uses too, such as for bulimia nervosa, premenstrual dysphoric disorder, and for impulsive behaviors that needn't be a syndrome in and of itself, but are a behavioral concern or problem that is part of another syndrome. An example, by the way, would be the autism spectrum disorders, or pervasive developmental disorders. A number of individuals with autism and Asperger's disorders have had very impulsive as well as compulsive behaviors. And these SSRI medications can be very helpful for both obsessive compulsive behaviors and impulsive behaviors. Next are the SSNRIs that selectively inhibit the reuptake of both serotonin and norepinephrine. These too are effective for depression and anxiety disorders. They work like an SSRI, but not only do they block the reuptake of serotonin, but they do that for norepinephrine as well. The medications in this class are fewer than the SSRIs. There's really only 3, but there are 2 forms of venlafaxine. Venlafaxine and desvenlafaxine. Very effective for depression associated with substantial anxiety disorder, including coexisting anxiety disorder as described for the SSRIs. And there's also a word of caution about sustained hypertension has been reported with venlafaxine, so checking blood pressures becomes important, So as a school nurse, if a student came in who was very uncomfortable and they had unexplained high blood pressure, it would be very important to determine if they've begun taking a new medication. And maybe it's venlafaxine. And by the way, Mila, I don't claim to be telling you anything new about what you would be considering in the new presentation of hypertension in an APS student, but merely adding venlafaxine or other psychotropic medications into your differential, if you will. Another is duloxetine, known as Cymbalta. Previously only used in adults as far as I knew, increasingly prescribed for youth nowadays. Found to reduce pain and other somatic discomforts that can be associated with depression. And I think that's currently depicted in a pretty popular TV advertisement and in magazines and on the internet as well, where it shows somebody who's very uncomfortable and rather incapacitated by their depression. And as they take this medicine, they look like they're much more comfortable and able to move about. And, it really speaks to how a number of people really do experience physical discomfort with depression. We don't see it as much in elementary school students, but we could see that in adolescent students and older adolescent students, okay, juniors and seniors, and those who are going to extended programs. And I'd have to say that in the relatively brief experience I've had with prescribing duloxetine, it does tend to be pretty effective. Lastly, in this group, mirtazapine or Remeron is being prescribed more often for youth. It's fairly sedating and therefore has been prescribed at night. Another antidepressant, bupropion, known as Wellbutrin, stands alone in its class. I've heard it referred to, even in textbooks, as an atypical antidepressant. It actually inhibits the reuptake of 3 neurotransmitters. However, it's primarily norepinephrine the most, followed by dopamine, and really not a clinically significant amount of serotonin. So we start to think of how we have the serotonergic antidepressants, which were just covered above in the SSRIs, as well as the SNRIs are serotonergic. Bupropion is not appreciably serotonergic. The addition of dopamine brings on some additional uses of this medication, especially for those who don't have much anxiety associated with their depression. And pardon me, Mila, I think that's really more of a point of how they don't need the serotonin activity of the other 2 classes.
So the serotonin is more for the anxiety?
The serotonin tends to be effective for anxiety, that's right.
Okay.
And for those who don't have appreciable anxiety, bupropion can be a good choice, especially if they have the more so-called melancholic features, that is, melancholic depressive features of low energy and motivation. So we can think of these individuals as having rather high inertia, hard to get going, hard to get them going, low energy, low motivation. Now, by the way, that's much more typical of high school students than it is of elementary school students during a major depressive episode. Elementary school students tend to be rather highly active and energetic even when they're depressed. Little positive reactivity to seemingly enjoyable activities and events, really don't respond to it. Facial expression, for example, doesn't change much. For concentration impairment, it's really an excellent antidepressant. That is to say, for depressed students who are having a considerable amount of concentration difficulties, such that they may be thought of as having coexisting ADD or ADHD, this can be a very effective medication. It's also prescribed for depression associated with disruptive and risk-taking behaviors. And it tends to not have the weight gain potential of the SSRIs, and in fact can actually be a good choice for individuals who are overweight. I mentioned there's some other antidepressants that we would touch on as well. All of these are older classes. Tricyclic antidepressants very much were prescribed in the 70s and 80s and even into the 90s. Very effective medications. However, a lot more side effect potential, especially cardiac. Trazodone used to be the alternative for cardiac patients who couldn't take the tricyclics. Has efficacy versus via serotonin activity. However, they tend to be very sedating at the higher doses required for antidepressant activity. And we find that that sleepy side effect of the medicine can be present even at lower doses. And many youth take trazodone at low doses for sleep. And those doses are akin to what doses diphenhydramine or Benadryl would be prescribed for the same purpose. Monoamine oxidase inhibitors, or MAOIs, are prescribed the least nowadays. They tend to have much greater risk of untoward effects that can include hypertensive crisis. You may recall, and many of us have not had to think about it for a while, but those who are taking MAOIs really have to eat a special diet, which is tyramine-free. And in fact, we still see MAOIs on the product labels for the SSRI antidepressants and other antidepressants, not to be taking them for an extensive period of time following the use of MAOIs. Nevertheless, they're still used in much more severe and refractory forms of depression, but more so with adults than with youth. Now, there is a strategy of augmenting antidepressants, both to get the biggest bang for your buck, if you will, and I mean that figuratively rather than literally, doing as much as one possibly can since medication is being taken, not that it makes the medication any less expensive. There are a number of individuals who have hypothyroidism, even mild hypothyroidism, even subclinical hypothyroidism, where only an elevated TSH is the clue to there being a subclinical hypothyroidism. And for some individuals that don't even have a thyroid abnormality, levothyroxine or L-thyroxine can be an important option for depression treatment. So what I'm saying is the medicine can be used to correct hypothyroidism, contributing to depression, even at very subclinical amounts. It also can be used as an augmentation agent prescribed not for reasons of hypothyroidism. Now, there are other ways of augmenting antidepressants, especially for the serotonergic medicines. And I find this is very worthwhile because it brings up the whole notion of synergism, that is, the action of two different serotonergic medications being more effective together because they complement each other with their different mechanisms of action. Case in point, buspirone or Buspar has been used for the treatment of anxiety, but it's been anything but robust. It's been a rather meek agent. However, combined with an SSRI antidepressant, for example, it can be effective, and it can help an SSRI antidepressant be more effective than it would be without the buspirone. I mentioned earlier trazodone in low doses helping with sleep. It too is serotonergic and works by a different mechanism than does an SSRI antidepressant such as Zoloft. So prescribing those two in combination can be more effective, again, than either one alone. Also can be helpful for augmentation in that strategy, also for sleep. And then tryptophan, the amino acid, in our diets, of course, and also can be purchased as a nutritional supplement. This agent is used to make more serotonin. It can augment antidepressant effects. It can also help with sleep. It's been shown to be an effective agent to use for individuals who have seasonal affective disorder. And more serotonin could definitely help the person afflicted with seasonal affective disorder. Lastly, L-methylfolate, known as Deplin, manufactured by PAM Labs in Louisiana, is actually a fancy B vitamin. Folate with a methyl group and the L stereochemistry. It's been an antidepressant augmenting agent. It's been effective for augmenting neurotransmitters, basically, for individuals with or without a medication, because folate is needed for the synthesis of the neurotransmitters. And some individuals have a genetic basis for not being able to get regular folate into the brain. It doesn't get transported through the blood-brain barrier because it doesn't have the shape or properties necessary to do so. However, L-methylfolate will get into the brain and help with additional synthesis of neurotransmitters. Well, having just talked about the class of antidepressant medicines that are used for the treatment of depression and anxiety, let's consider which psychotropic medications are used for more severe depression and other mood disorders. So what I'm really saying here is the first medicines that we covered are very practical and useful for prescription to students for their depression and anxiety who are experiencing those conditions for the first time, and welcome Amelia, who are experiencing those conditions for the first time and can be done so in a very practical way in a school-based health center. There are other agents that are used for more severe depression and other mood disorders. Mila, I'm going to interrupt just for a moment to introduce Amelia, who has joined us here at Studio Envision. Amelia, I think you met Kevin earlier.
I did.
Amelia is the Behavioral Health Manager with the Office of School and Adolescent Health, Department of Health. And Mila is a school nurse at Chaparral Elementary School who's currently attending the webinar.
Nice.
So she's having a private webinar, and now it's the two of you.
Great.
So welcome. We've been talking about selecting medications that are effective for student depression and anxiety.
Okay.
And we just covered those that are more like the front line, really easy to use, ones to choose initially for treatment of depression and anxiety.
Great.
So now we're taking a look at others that are prescribed for more severe depression and other mood disorders.
Okay.
They tend to be prescribed less in school-based health centers because of some of their complexities, but we often encounter students who are prescribed these medicines by providers elsewhere. And these medicines, by all means, can be prescribed in school-based health centers. Mood stabilizers are a good example. Lithium preparations are time-honored. We know that they were the very first mood stabilizers to be prescribed. Then anticonvulsants came on the scene, and they're really effective, very helpful, and like lithium, they need close clinical monitoring and even lab monitoring. A couple of these, lithium as well as lamotrigine, have antidepressant efficacy. And the newer atypical antipsychotics also have mood stabilizing agents or activities. These newer atypicals are listed at the top part of the slide, whereas the older neuroleptics are listed toward the bottom. And I'm just going to mention, Amelia, if you're interested, we have the handout for today's presentation on our Envision New Mexico website.
Oh, perfect. Okay.
And Mila, I want to confirm that you know that you have access to that as well?
Yes. Yep,
Okay.
I've saved it to my desktop.
Great. Well, and I hope you're finding it useful. You can see that there are many newer atypicals that have come out and have been used since about the mid-90s. They have the activity of blocking both serotonin and dopamine activity. With these antipsychotics, they have mood stabilizing and antidepressant actions. They've been used not only for primary psychosis, but for conditions where there's aggression to self or others and mood lability and targeting those features. Great concerns about these medications include weight gain and the possibility of metabolic syndrome leading to the development of diabetes. Then there are the older neuroleptics, Haldol and Thorazine being the most popular among them. They block dopamine only to a clinically significant extent. So we can think of this as, with both agents, the blocking of dopamine is really where the antipsychotic activity is. It's the serotonergic activity where they have their effect on mood.
Where does paliperidone go? Is it a...
Haloperidol is one of the haloperidol.
Yes.
Haloperidol, that would be Haldol.
Haldol.
Yeah. And there's another one, by the way, called droperidol, very potent, which is also an older neuroleptic. We tend not to prescribe these as much. They have more side effects. And we can, by the way, have many of the same kinds of nervous system side effects with the newer atypical antipsychotics, but it tends to be not so persistent and pervasive. It doesn't happen with as many individuals as it did with the older medicines. But one of those neurologic side effects, Parkinsonism, definitely can occur with a prescription of the newest atypical, which is Abilify. And I've really been pretty impressed by the development of Parkinsonism in individuals taking that newer agent. Lastly, let's consider which psychotropic medications have been prescribed to students before their depression and or anxiety are identified in school-based health centers. And Mila, I think the counterpart is these could be students who could end up coming in to see you because they're feeling bad and their moods are dysphoric. They're not as interested in doing things and they're not enjoying things as much and they're having a harder time getting through their day. And it may not yet be known exactly whether they're depressed and or anxious, but that very well may become apparent to you as they come to see the school nurse.
Yep.
Well, earlier on I had mentioned to Mila that anxiolytics or anxiolytic is really becoming an outdated term because benzodiazepines are being used less often as the first line anti-anxiety medication that they used to be. They're still used for shorter term treatment of acute severe anxiety, such as if a student developed a very severe panic attack. It might be helpful to give them a short-acting benzodiazepine to help them get through that. If they experience something catastrophic and had an acute stress reaction, this could be effective for them like on a one-time basis. For severe insomnia, for agitation, severe phobias. These medicines definitely have a place, but there's much more of a drug effect that is dose response. So they take the medicine, they get the effect for X number of hours, and then the effect goes away. Whereas with the serotonergic agents we covered earlier, the SSRIs and the SSNRIs, we're developing a steady state blood level with those medicines. the anti-anxiety effect comes from that blood level, and it's sustained rather than getting that dose response up and down, up and down. Okay? Then there are alpha-2 agonists. Students may have been prescribed these for ADHD. They're very effective medicines for targeting impulsivity and impulsive aggression, which may be part of ADHD plus something else. To clarify, impulsivity is a hallmark feature, one of the 3 hallmark features of ADHD. Another one is hyperactivity, and this medicine might be effective for a student who primarily has that impulsive, hyperactive form of ADHD. But if they have ADHD with another condition or another condition alone, such as conduct disorder, where they're also very aggressive and very impulsive ways, these medicines are very effective for that. It also can be very effective medicine for insomnia, and it can help with anxiety. So here again, as I mentioned earlier, Mila, all 6 of those classes of medicines can be effective for anxiety in some way, shape, or form, but we don't necessarily use all of them for it. Okay? By the way, the main action of these medicines is to block norepinephrine from its outflow from the brain. And it comes primarily in way of 2 different agents, clonidine and guanfacine. I tend to like the guanfacine better, longer acting, fewer side effects overall. Very effective medicine. But for somebody who really needs the help from this medicine, or this kind of help, it's a very effective tool. And guanfacine can be used during the day, morning and afternoon, clonidine at night, when clonidine tends to be more sedating and can help somebody sleep. Psychostimulants, primarily, of course, for the treatment of ADHD, they act through the combined effects on dopamine and norepinephrine systems in ways that are really not fully understood. And I chuckle as I say that because virtually every source I go to describes the mechanism of action of psychostimulants differently, which speaks to how limited our knowledge is of them. Some of the sources will really say it's all about dopamine because these are dopamine agonists. They stimulate dopamine activity in the brain. By the way, antipsychotic medicines are dopamine antagonists. They block the action or the effects of dopamine. So those are contrary activities. And sometimes we find individuals who are prescribed both psychostimulants and antipsychotics, and it's questionable how efficacious that is. If it's different, those actions at different parts of the central nervous system, maybe that's still okay. But we know about methylphenidate and amphetamines. They're both time-honored. It's really a matter of newer preparations coming out. With amphetamine, Vyvanse, which is a prodrug form of amphetamine, is the newest form of this class now. It's really not effective until it goes through the body's metabolism by the liver. Methylphenidate is now available in much longer acting preparations, and so is Adderall, the mixed amphetamine salts. Our caveat is that there are a number of students out there who, as Mila, you may have heard me talk about before, are misdiagnosed with ADHD, whereas they really have depression and or anxiety. And when they are prescribed psychostimulants, it can really worsen their depression and anxiety. So that's where I see psychostimulants really fitting into today's topic about choosing medications for effective treatment of depression and anxiety. Some other medications to consider atomoxetine is approved by the FDA for ADHD, and it really has the greater efficacy for the inattentive type of ADHD, also known as ADD. It's been found to be less efficacious than psychostimulants for improving the combined type of ADHD, which has the hyperactivity, impulsivity, and distractibility, as well as for the combination I mentioned earlier of impulsivity with hyperactivity. It has the potential to be helpful for depression and anxiety, as it's really a selective norepinephrine reuptake inhibitor. And it's not an SSRI, it doesn't block the reuptake of serotonin, but it does block the reuptake of norepinephrine. So one could think of this as being similar to bupropion, but not having the dopamine activity combined with the norepinephrine that bupropion has. It just has the norepinephrine blockade. And just as an aside, the pharmacology of psychostimulants was mentioned earlier as involving dopamine and norepinephrine. Agents that have been effective in the treatment of ADHD that can act on norepinephrine alone, like atomoxetine and the alpha-2 agonists, guanfacine and clonidine, tend to be less effective than the psychostimulants. And theoretically, it's thought because they act on one neurotransmitter system and not both. Diphenhydramine, known as Benadryl, actually can be very effective for treating insomnia in youth, in addition to trazodone that was mentioned earlier. And as an aside, I want to mention that we really use Benadryl and trazodone so much more for insomnia in youth than the sleeping agents that are popular for adults, including benzodiazepines. They just don't get prescribed as much for kids unless they can't get the benefit from these other agents. Diphenhydramine can be used for anxiety as well in ways that were described for benzodiazepines earlier, like for acute anxiety, one-time use. Tends to have a sleepy side effect. When used in these ways, it dries out nasal passages as well, of course. And I added that it's a safe medication for behavioral discontrol in preschoolers, because sometimes there's a need identified for a preschooler who gets really out of control, and people want to know what to do, and we all get really worried about prescribing medication to a preschooler who looks as young as a toddler. They may be 3 years old. Diphenhydramine can be very effective, and it's available over the counter in liquid form. So that's what I end up doing with a number of those referrals. So let's look at a couple dosing guidelines for student psychotropic medication prescription. I don't think there's anything surprising here, especially on the first point, starting low and going slow. So Mila, if a student comes in to see you and they're not feeling good, and you hear that they recently were started on a new medication, it could be helpful to include in your correspondence with the involved adult, the parent or guardian, other caregiver, how an adjustment of the dose may be needed. You may be able to include in the discussion what the dose is in the range of the medication, and really can be a very good opportunity to draw upon the parent or other caregivers' understanding of the dosage range, because they really need to know that. So in terms of medicines we've talked about today, maybe a student was started on some guanfacine for impulsive behavior and hyperactivity. And the parent says, oh yeah, they were started on a whole pill. Well, a whole pill is 1 milligram. And a half a tablet would probably be a more effective way to start. Okay? But the eventual dose can be as high for youth as for adolescents. Youngsters have such high metabolic rates that even with their little bodies, they can require an adult-sized dose, which for me, in my training and practice, was kind of a revelation. So I wanted to ask at this point if there are any questions, concerns, protests, thoughts, comments, beliefs that we haven't gotten to today.
That was my
I
question.
do have a couple of questions.
Yeah, please. You can go. Go ahead.
Last week you mentioned some of the antidepressants, the SSRIs, and mania. If like they were bipolar, it might make that come about.
Yes, I think you're
I
referring to...
don't remember which one it was.
I think you were referring to the potential for SSRI antidepressants to activate an individual who has a predisposition toward bipolar disorder to develop a manic or hypomanic state. Is that what you were referring to?
Yeah, and I was wondering, was that just with Zoloft, or was that with all of them?
All of them. And in fact, I would say, Mila, with all of the antidepressants. That's really true. And it's also true for the psychostimulants. Okay? But to answer your question,
It was really just if it was all of the SSRIs, because I think I
all
remember.
of these SSRIs, all of them.
Okay.
Okay?
Okay.
And that can happen with the SSNRIs, and it could happen with bupropion. What's interesting, and it can happen with the tricyclic antidepressants, and with trazodone, and the monoamine oxidase inhibitors.
Oh my gosh.
Okay?
So you better be diagnosing right.
And it could happen when augmenting with another serotonergic agent. But the distinction is that the serotonergic agents tend to do it more than something that is not serotonergic, such as bupropion doesn't have a significant serotonergic activity. So for an individual who may be developing bipolar disorder but is clearly depressed and not showing signs of hypomania or mania, bupropion could be a good choice for them. There are some individuals who have that predisposition who really have not actually developed mania or hypomania, who have been started on bupropion and have done pretty well. And I'd have to say it's been an approach I've sometimes taken in the school-based health center when I really haven't had the resources immediately available to me for starting an anticonvulsant mood stabilizer, and I don't want to start them on a serotonergic agent plus one of those mood stabilizers.
Okay.
And I also mentioned to you that I didn't go into detail about the tricyclics, but some of them are serotonergic versus norepinephrine. So these two here, the amitriptyline and imipramine, and clomipramine are more serotonergic. The nortriptyline and desipramine are more noradrenergic. They involve norepinephrine. And this is a distinction that we used to think about a lot more when we were prescribing these medications. But my point is we would take a similar strategy. Somebody seemed like they might have more of a predisposition toward bipolarity. I would probably choose for them desipramine or nortriptyline rather than the more serotonergic imipramine or amitriptyline. And this is where it gets to be important to have the strategy for selecting the agent, as well as making a comprehensive assessment. I also wanted to mention to you that one of the most robust manic activations I ever saw was a teenager with a propensity for bipolar disorder, previously undiagnosed, who was prescribed, I think it was dextroamphetamine, dexedrine, and became floridly manic. So it isn't just with the antidepressant medicines, but with the psychostimulants can do that too.
So then if you take it away, does the mania go away, or are they really bipolar?
Well, it's the distinction between the illness or syndrome on the one hand versus the state within that syndrome. So for somebody who becomes manic, they have bipolar disorder. But by taking away the activating medication, their state will descend from mania, but they still have bipolar disorder.
Okay.
Is that answering your question?
Yes, that does answer that question. Yeah.
Okay. Amelia, you were starting to ask a question earlier.
Yeah. So my question is in regards to the amount of prescriptions. So, I've had a 14-year-old patient who was on Seroquel, and, the levels that they were on was astonishing. But it was because they said he was going through a hormonal change, and that was the biggest thing. And how do you regulate that as children go through puberty and adolescents kind of change with that? Because is it the medication's ineffective, or is it because they're hormonally imbalanced going through puberty? How do you know the difference?
I think that the hormonal aspect is speculative in most clinical circumstances, where somebody who previously didn't have the characteristics of their illness or could be maintained on a lower dose of medicine, and it was found that they were requiring more and more, and there's speculation while they are going through puberty that could be causing the difference in needs in order to stabilize mood. What I think is most important is that usually these really high doses of medicine can be arrived at very deliberately, very gradually in individuals who didn't respond to lower doses. And I can think of a past situation I was working in clinically, that if you came upon that teenager at that treatment center and saw the dose of Seroquel that he was taking, you'd be astonished.
Right.
But when knowing the history of the case and how close the clinical monitoring was, while gradually raising the dose and eventually seeing that there was improvement at, say, twice the maximum dose that's described in the product information.
Wow.
It's really pretty astonishing. Sometimes there are these circumstances that warrant a higher dose. And I think if they are approached with good clinical acumen, it can really be an okay thing to do.
Okay.
But they usually tend to be the minority of individuals who have those kinds of extreme dosing requirements or doses that are attained in order to get something beneficial.
Okay. So it's not so much that, it may be their size, or...
It could be their size, it could be their metabolism, and maybe they're metabolizing the medicine differently during puberty. But when I said conjecture or speculation, there usually is not a test that can be done that shows what the change is in puberty.
Okay, that makes sense.
That causes the medication needs or dosing to change. Well, there's a last section here that has to do with an integrated approach to psychopharmacotherapy in school-based health centers. And Mila, while I think here too, there are aspects that are not directly related to the school nurse's office and the situations that arise there, I think that there are some aspects that are applicable. Because we don't have to be the Lone Ranger in the work we do. We welcome the integration of care to help students. I think we all agree we want that. And when we're in school-based health centers, we really rely on the integration of care, more specifically a behavioral health provider, which could be Amelia, for example, working along with a primary care provider who could be a nurse practitioner in one of our school-based health centers. Working together, they can accomplish prescribing of this psychopharmacotherapy, that is, prescribing these medications in therapeutic ways that could not be accomplished really by either alone.
Right.
Okay. There's treatment team involvement that permits this to be accomplished, that is carried out both with students present and when they're not there and having our team conferences. Our team conference occurs when the students aren't there. We practice a continuous collaboration to make this possible. And we look at this programmatically to formalize team conferencing to make sure there are these opportunities and develop prescribing and monitoring procedures. So, for example, the whole concern about suicidality with prescribing antidepressant medication was covered in part 1 last week. But it's really a good example of how the risk and concern diminishes when students are monitored frequently. And school-based health centers, as well as the school nurse's office, have this in common. How it's accessed and utilized differs, but Mila, I would think that if a student's physician is concerned about how a student is going to do with a medication change, for example, they're not responding to the usual dosage range of a medication, so that range is being exceeded, that physician could access the school nurse, and in that case, Mila, the services you provide would be a real great asset for that student's treatment plan. We need to begin our collaboration early, as we did with our twins, and I often joke about, of course, in their tweens, they're just as cooperative as they were at 17 months. But in our collaborative overview, we aim to integrate our care within the school-based health center, collaborate with the school. So Mila, if we had a school-based health center at Chaparral Elementary School, then the behavioral health provider and the medical provider would be collaborating with you and the school counselor and social worker, your assistant, just to name a few, to really expand these services and care to students. And we would attempt to coordinate the care with the community providers and agencies as well. So that's really the brief overview of collaborative care as it pertains to the integrated school-based health center prescribing. And I mentioned earlier that what can really be of assistance when a behavioral health provider and a medical provider are integrating care is to have a resource to help with problem solving in areas that some additional support and consultation are needed. And that's where telepsychiatry consultation comes in. So this is something that's available to New Mexico pediatric and school-based health center providers who do not have a psychiatrist on their team. Mila, I welcome you to access this as well. It's a program that developed several years ago. Fall of 2006 it began at OSA, So I'm going into a little bit of that history for Amelia's benefit, and that's when I and some others who are currently here at Envision were over at OSA.
Okay.
And I was primarily there to develop this program.
Gotcha. Okay.
Okay, so Mila, if there is a concern that came up in your school nurse's office about the mental health needs of a student where other resources were not accessible enough for you to obtain the answers that you need and you felt like additional consultation would be helpful, of course you would be welcome to access this.
Okay.
Great. So in your handout there are some additional tools and websites, American Academy of Child and Adolescent Psychiatry being foremost among them. The GLAD PC is also a great resource. And some publications, including more by the American Academy of Child and Adolescent Psychiatry and a couple textbooks that I have found useful. So Mila, we know you're there. You'll get your CME without any problem.
Thank you.
And I think Amelia could be a candidate for that as well.
I'm not sure.
We'll just have to see what we
It's
can do.
okay.
30 minutes. But yeah.
Okay, in the future. So as far as resources go, here are our personnel, including Kevin and Clancy, who was described on the previous slide, who supports the telepsychiatry consultation, and others. So I've gone over a couple minutes. Mila, thank you for joining us. Pleasure having you again this week.
Thank you for having me, and I've learned quite a bit today. Thank you.
Great, glad to hear it.